Thank you very much, Professor Madoff. Many thanks to SIO, CCMA, and Econ and Zinc Microwave Company for setting this very interesting webinar. These are my financial disclosures. And for the next few minutes, we will try and change gears, moving from malignant to benign bone tumors. We will focus upon osteoid osteoma, and we'll speak a bit at the end of the presentation for osteoblastoma and percutaneous ablation of other benign tumors in musculoskeletal system. Starting with osteoid osteoma, this is one of the most common benign bone tumors, comprising approximately 13% of all cases. It is encountered most frequently in male patients between 7 and 25 years old. And these patients, they usually report nocturnal pain, which is localized around the bone lesion, and it is typically relieved by non-steroidal anti-inflammatory drugs. And in addition, these patients, they might report sleep deprivation, growth disturbances, bone scoliosis or deformities. More than half of the cases of osteoid osteomas are found in long bones, and most commonly in femur and tibia. Approximately 1/3 is found on the spine, hands, or in the feet, and less than 20% can be found in the skull, scapula, ribs, pelvis, in the mandible, and patella. The center of the lesion, the center of osteoid osteomas, is called the nidus, and here you can find very high levels of prostaglandins, which are actually responsible for the whole inflammatory process that can be found in patients with osteoid osteoma. The nidus center is usually the most highly mineralized part, and it's displaying various amounts of mineralization. Osteoid osteoma can be classified on the basis of X-ray findings into cortical, which is the most common type of osteoma, into medullary or subperiosteal, which is the least common osteoid osteoma type. Additionally, these lesions, they can be classified on the basis of axial imaging into subperiosteal, intracortical, and endosteal or intramedullary lesions. And you can see in this slide examples of subperiosteal osteoid osteoma, intracortical, which is located inside the cortical bone, intraosseous, and medullary types of osteoid osteoma. Spinal osteoid osteoma is considered one of the two separate subtypes of the lesions. They most commonly are found in the lumbar spine, followed by cervical and thoracic levels, and last but not least in the sacrum. Most commonly in spinal osteoid osteomas, the nidus is located in the neural arch, that means in the posterior parts of the vertebrae. These patients, they commonly report radicular pain, gait disturbance, limb atrophy, and painful scoliosis due to the asymmetric muscle spasm. When scoliosis is present, the nidus typically is on the concave side on the lumbar curvature. Another separate clinical entity is the intra-articular osteoid osteoma. Here we have severe inflammatory changes that can confound the diagnosis. Additionally, we can have different imaging findings, including reactive cortical thickening, including minimal or absent reactive cortical thickening, and that is a finding believed to be due to the lack of cambium, which is the inner level of the periosteum. From all the joints, hip is the most commonly involved, followed by ankle, elbow, wrist, and knee in the sequence of patients. As far as imaging is concerned, we can use it in order to diagnose osteoid osteoma, in order to localize the nidus prior to the therapy, and for imaging guidance during the ablation. From all the axial imaging, computed tomography at the moment is the modality of choice. MRI imaging findings, they can be deceptive. Although the technique is governed by excellent specificity and sensitivity in case of osteoid osteoma recurrence using perfusion sequences. As already said, computed tomography is governed by higher sensitivity and specificity when we want to depict the nidus for the first time. This is because in MRI imaging, the signal of the nidus in most of the cases is similar to that of the cortical bone. For computed tomography, we can use thin section, axial, and longitudinal multiplanary formatted CT images, which can be obtained with a bone algorithm and viewed with bone window settings. On the other hand, in order to improve and increase the spatial resolution, we can use contrast enhancement in the magnetic resonance imaging. And here you can see the problem with the signal. We have a cortical osteoid osteoma that you can barely see on the CT imaging. However, in T1 weighted sequences, you cannot see the nidus because it has the same signal with the cortical bone. And this is why computed tomography is most commonly used for the first-time diagnosis of osteoid osteoma. If you want to use MRI, you should implement arterial kinetic pattern of enhancement post intravenous injection of gadolinium in order to be able to locate easily the nidus with MRI. Differential diagnosis includes stress fracture, intracortical abscess, intracortical hemangiomas, chondroblastomas, osteoblastomas, and compensatory hypertrophy of the pedicle in the spine. Nowadays in the market, we have different techniques that can be used for osteoid osteoma ablations. The vast majority of these techniques are with minimal invasiveness. We also have high-intensity focused ultrasound, which is lacking invasiveness at all. A lot of things have fallen into place since the first literature reports of osteoid osteoma ablation back in 1982 and 1992 from Rosenthal, who was the first one to describe percutaneous ablation of osteoid osteoma with radiofrequency. Nowadays, in the literature, you can find numerous studies for osteoid osteoma ablation using a wide variety of techniques, including laser, radiofrequency, plasma radiofrequency, microwave, cryoablation, or MR-guided HIFU. And all these are reports. They are including a higher or lesser number of patients, but all of them, they have in common very high safety and efficacy rates. All these techniques, from laser and radiofrequency to microwave, cryo, and HIFU, they are governed by similar rates of success, recurrence, failure to treat, and complications. If we focus on pediatric population, in children you have certain studies, one from 2008 with 68 patients, once again reporting very high rates of primary clinical success with very low rates of complications and local recurrences. Even in the literature, you can find numerous studies using, apart from radiofrequency, laser, cryoablation, MR-guided HIFU, either computed tomography or cone beam CT. What you will need during ablation of osteoid osteoma is the presence of anesthesiologist. The nidus, due to the inflammation, is a very painful location, and you need the anesthesiologist. You can use epidural anesthesia, conscious or deep sedation, or general anesthesia, but when you're puncturing the nidus, be certain to have the anesthesiologist right next to you. Apart from the anesthesiologist, you will need a trocar in order to access the nidus. You can hammer or you can drill your way inside the nidus. In this latter case, it's much more comfortable when you have an excess of periosteal reaction. And of course, you will need the bone trocars. In the market, there is a wide variety of trocars. You can depend your choice on how much cortical bone, how much periosteal reaction you need to cross. In the literature, you will find numerous studies supporting application of radiofrequency ablation for osteoid osteoma. And actually, nowadays, percutaneous radiofrequency ablation is considered the gold standard technique for the treatment of osteoid osteoma. This is a case of osteoid osteoma in the tibia treated with percutaneous radiofrequency ablation under computed tomography. We have used a bone trocar inserted inside the lesion. Coaxially, we have inserted the bone biopsy needle for sampling. Mostly, you don't need that for diagnosis, you need it for medical legal purposes. And then coaxially, we have inserted the radiofrequency electrode. You remove the trocar at least 1 centimeter away from the active tip, outside the expected ablation zone, and you can proceed to the ablation. And this is the final CT scan. After removing everything, you can see the intraosseous root ending up inside the nidus of the osteoid osteoma. This is our case series with osteoidostomas and excessive periosteal bone. Instead of hammering, we are drilling our way inside the lesion. That can be much easier than passing with a hammer and a bone trocar through this very dense cortical bone. Once you are inside the lesion, you are coaxially inserting the bone biopsy needle and then the radiofrequency electrode and proceed to percutaneous ablation with very good results, no matter where the location of the nidus is found. One variety of the approach is coming from United States. This is a case from Sean Stanton. You can access your way with a bone trocar, and then you can use peel-away sleeves in order to have an easier access to the nidus. And then coaxially, you can insert your radiofrequency electrode, microwave antenna, or whichever ablation product you want to use. And of course, all these are done under computer tomography in order to have the highest spatial resolution. Apart from children, we have applied radiofrequency ablation in intra-articular osteoid osteomas. Our major concern here is the cartilage inside the joint. So keeping in mind that all kinds of electrodes and probes, they are releasing the energy towards the posterior part of the active tip. That's why we are targeting towards the joint. We are putting the biopsy needle for sampling, then the radiofrequency electrode. Here is the part where you have your ablation zone, and it will extend posteriorly, preventing as a prophylactic measure for the cartilage joint. And in the computer tomography, at the end of the ablation, when you have removed everything, you can see the interosseous root ending in exactly inside the nidus. If you want to change gears from radiofrequency to microwave, in the literature, you can find studies applying microwave ablation for osteoidosteoma. Here you have a wide variety in the length of the active tip that can range from 0.4 to 4 centimeters. So in certain cases, and depending on the length of the active tip of the microwave antenna, you will need to change your approach. Most commonly, the authors are using intraosseous approaches in order to not to have non-target ablation in sensitive location. This is a case of microwave ablation of osteoidosteoma. They came through the sacroiliac joint. They ablated this sacral osteoidosteoma. Apart from radiofrequency and microwave, in the literature, you can find cases of cryoablation. One advantage of this technique, according to the literature evidence, is that you don't have to puncture the nidus itself. You can place the cryoablation right next to the nidus, and the ice ball will extend inside the osseous part, including the nidus. A lot of evidence is upon laser photocoagulation of osteoidosteoma, specifically for the spine and for for locations where sensitive structures are close by. Once you are there, with a very thin needle, you can insert your laser fiber. Specifically for the spine, you can apply gas dissection as a prophylactic measure, and then you proceed with ablation of osteoidosteoma. As already said, MR-guided HIFU lacks any kind of invasiveness. Patient is placed on the MR hardware, and then you can proceed with the HIFU technique, and immediately after you can see that there is no vascularity. And the greatest advantage of this technique is that you can have thermal mapping during the ablation. In the literature, the magic number of success is between 95 and 97% of the reported cases for all kinds of ablation techniques. The complication or recurrence rate are below 2%, so percutaneous ablation at the moment is the gold standard. We have the highest level of evidence for radiofrequency and laser. Cryo, microwave, MR-guided HIFU seem to be the new kids on the block in the treatment of osteoidosteoma. The aggressive cousin of osteoid osteoma is osteoblastoma. These two are essentially indistinguishable on the routine histologic analysis. However, osteoblastomas, they have a diameter which is larger than 2 centimeters. Osteoblastoma patients are usually younger than 30 years of age, and the lesion is once again more common in males. The most common locations in the skeletal include the spine, especially the posterior elements and the long bones. We have 3 different imaging presentations of osteoblastomas. The first one is looking like a giant osteoid osteoma with a diameter more than 2 centimeters. In the second imaging presentation, you can have lesions with an expansile appearance, with a mineralized matrix and a narrow zone of transition. And this is typical appearance for the spinal osteoblastomas. And last but not least, in long bones, you can have aggressive lesions with prominent bone expansion, partial cortical destruction, and soft tissue infiltration. As already said, most commonly, both lesions can be found in males. However, the age is somehow older in osteoblastoma lesions. This is a case of an intra-articular osteoblastoma. It has been biopsy proven. This is the biopsy needle, followed by electrode placement and radiofrequency ablation. You can find in the literature that radiofrequency and cryoablation as ablation techniques, they can be really friendly to the cartilage. This is a histologic analysis of articular cartilage after ablation, and there were not significant effects both of cryo and radiofrequency on tissue architecture compared with control samples. Moving on from osteoblastomas to benign tumors, I will quote the writings of a review paper from 2012 by Daniel Rosenthal and Matt Karlstrom. And in this paper published in Radiology, both authors are saying that essentially any small, well-defined lesion at imaging can be treated with radiofrequency ablation. We can use percutaneous ablation, and that will include radiofrequency, micro, cryo, and laser for all kinds of benign lesions, starting with aneurysmal bone cysts. These are benign, osteolytic, expansive, and very hemorrhagic lesions. They can be found as primary cases or classical ABCs. We can find aneurysmal bone cysts secondary associated to another lesion, or rarely they can be found as solid tumors. These are locally aggressive tumors of intermediate malignancy, and the vast majority of ABCs, they occur in young patients less than 20 years of age. This is a 6-year-old male patient. He was twice operated for this aneurysmal bone cyst in the femoral bone. Then after the second operation, the patient was referred to our department. We tried to treat that with transarterial embolization, followed by cement injection. Here we are using pyrophosphate cement because this is a very young patient. 2 months later, honestly speaking, there is not much of a difference on the MRI prior and after our attempts. So we went for a second attempt. Here we used microwave ablation. You can see the antenna inside the aneurysmal bone cyst, once again followed by injection of pyrophosphate cement. 6 months later, this is the X-ray of the child. You can see we started from here, we ended up here. I do agree that this is not a good looking result, but the child is functional, it can run, it can play without having any symptoms. And despite the fact that we are using percutaneous ablation, and this is a force that can provide good, always there is a dark side in the force. When you are heating, you can destroy spinal cord and peripheral nerves at temperatures over 45 degrees. When you are freezing, the same result, you can have it at temperatures below 4 to 6 degrees. That's why the first thing you need to be aware of is your anatomy. You need to know where your sensitive neural structures are located and try to prevent your ablation zone extending to up to this location. Additionally, you can have thermal protection techniques, and here you can include passive protection techniques, including thermocouples for temperature monitoring and intraoperative neurological monitoring systems. And of course, you can apply active thermal protection techniques for insulation. You can use gas or hydrodissection. And you should always remember the skin. You can use gloves with warm or cold sterile water, depending on the ablation technique that you are using. This is a case of an osteoid osteoma, really close to the skin. A second needle has been inserted in order to inject dextrose mixed with local anesthetic in order to increase the distance between the skin and the nidus. Another good way here is you have a sterile glove filled with chilled water in order to provide cooling of the skin during radiofrequency ablation. This is an osteoid osteoma. The nidus in the fibula is located right next to the perineal, to the common peroneal nerve. Here we have used a bone trocar for access. Coaxially, we have inserted the radiofrequency electrode. Right next to it, a second needle, we injected dextrose 5% mixed with contrast medium in order for our solution to be visible, and the whole ablation process was performed under continuous monitoring of the temperature and monitoring of the neural function with evoked potentials. And this is the final result with very good ablation and application of all these protective techniques. A case of facet joint osteoblastoma. This is biopsy proven. You can see the images from the biopsy. Then we proceeded to the ablation in a second session. You can see that we drilled our way inside the osteoblastoma after we had applied gas dissection in order to push away the spinal cord from the expected ablation zone. And here is our radiofrequency electrode inside the osteoblastoma. The whole ablation process was performed under evoked potentials. 1 year after, you can see the lesion. The patient is 100% pain-free with no problems of complications. Last but not least, you should be aware that even for osteoid osteoma, you can have complications, and sometimes you can have late complications, and these complications will depend upon your access route and your access site. For the femur, we know that the highest amount of forces are applied in the lateral cortex. So if you can, please avoid having your access site in the lateral femoral cortex. You should always remember that according to the literature, this is a late case of fracture after osteoid osteoma. The risk of fracture of the proximal femur following the placement of lateral metal implants is well known in orthopedic trauma. You should always remember that bone undergoes a period of increased fracture risk, in part due to the access sites, and you should pay caution on choosing these access sites. Specifically, beware of the subtrochanteric and lateral femoral cortical regions. Closing up, for osteoid osteoma, the ablation, percutaneous ablation, specifically with radiofrequency and laser, is the gold standard therapy. We have the highest cumulative data in terms of results and evidence for long-term efficacy with radiofrequency ablation, and laser, cryo, microwave, and MR-guided HIFU are the new kids on the block for percutaneous ablation. If you are dealing with osteoblastoma, you should apply more aggressive ablation sessions, especially when the lesion is located in the long bones. Always remember to know your anatomy, take care of sensitive structures, and don't forget that bone can be injured during all forms of ablation. Thank you very much for your attention. Before I close up and hand over the virtual microphone, I would like to remember to all of you to join SIO with being new members to this Interventional Oncology Scientific Society. Thank you very much.